Welcome everyone to today's meeting of Health and Wellbeing Committee, City Council. This is a public meeting and members of the public and press are permitted to report on the proceedings. Reporting means filming, photographing, making an audio recording and providing commentary on proceedings. Please note this meeting is recorded and streamed live. These recordings are published on the relevant meeting page of the Council's website. By choosing to attend this public meeting, you are deemed to have given your consent to being filmed or recorded and for any footage to be broadcast or published. If the alarm sounds, the premises must be evacuated immediately. Do not spend time collecting personal belongings. All emergency escape routes are clearly signed. Once you have left the building, the assembly point is in the High Street opposite the Guildhall. Members and other speakers are reminded to use their microphone when speaking. Agenda item 1, appointment of substitutes.
Yes, thank you, Chair. We do have two substitutes with us tonight. We've got Hannah Cooper, who's here for Neil Lawrenson. We've also got Karen Lawrence, who's here for Sarah Murray.
Thank you very much. Any declarations of interest? I would have expected you to.
Yes, I want to mention, as we're talking about the Creative Care Board update,
Thank you very much. Okay, thank you. Public participation. I believe we have a couple participants, one of whom has just arrived in the nick of time. And we've also had, and then we've had a message through our customer walk-in service, our customer service. Gentleman went in and wanted to bring this to committee. That's correct. Mr. John Grove, who lives in Elgar Court, Rainbow Hill, and he'd like to express his concerns regarding the proposed electric bike scheme in the city, which is one of our agenda items today. His main concerns are the bikes are so quiet that pedestrians and other road users cannot hear them. People cannot be trusted to use the bikes responsibly in the manner in which the scheme is intended. He has seen reports of electric bikes catching fire even when they are not in use. Mr. Grove has witnessed a similar scheme in Redditch and had seen bikes just abandoned randomly across the town. He says he is not against the idea of the scheme in principle, but feels that it is open to abuse, and he does have concerns about the safety of the bikes. Thank you to Mr. Grove for thoughts on. Mr. Collier, have you got your breath back?
Well, we'll see, just about. Thank you, Chair. Folks, for those who don't know me, my name is Rob Collier. I'm Secretary of Bike Worcester, a regular at this committee meeting. Thanks for having me again. I'm here to talk on the topic of the cycle hire scheme. Just a few observations from the Bike Worcester community about the cycle hire scheme and a few thoughts for you in advance of that agenda item. First of all, it's such an exciting opportunity. It's such an exciting moment for Worcester City. I was saying to the gang, there may not be a bigger moment for cycling in Worcester than this one. It's a huge source of excitement for us. you couldn't do anything, I don't think, to raise the profile of cycling in the city and what it means for commuting and everyday journeys by bike. So I applaud the members and officers for bringing this scheme to the council. It's really exciting to hear that it's in touching distance. So that's the first comment. Second comment, just for matter of record, massive thanks to David Sutton and his team. Bike Worcester have been engaged through 12 months and more with David and his team. Had the opportunity to feed ideas into this scheme and into others. We've got a really positive dialogue with the City Council officers, and it makes a huge difference because as members of the community we're able to disseminate messages and disseminate information to the group, and generate ideas. There's a massive amount of expertise within Bike Worcester Group, not only because we move about the city in cycling, but also lots of our members, this is their day job. So we've got lots of experience and lots of advice and guidance to offer officers and to members. So to that end, the invite goes out again to all members that if we can help at all, please do get in touch. We're very active, we're very enthusiastic, and we're more than happy to help. Just a couple of additional thoughts. You may know, and if you don't, I'll tell you, Worcestershire has a reputation nationally for being a really hostile place for cycling. Our name precedes us. If I go to events or if I talk to other campaigners or other advocates around the country, they offer their sympathies to me and to others for being from Worcestershire. We're known as an area where cycling is really difficult. And we have a level 0 score from Active Travel England in terms of cycling infrastructure and ambition at County Council. And I think that's really important context to consider when we're thinking about the cycle hire scheme. I know that the map of stations that's in the report is only a proposed map, but if that were to be the case, the routes between those nodes of where the cycle stations or hubs might be, some of those routes are extremely unpalatable for a novice or an experienced cyclist, and that lack of routes poses a very significant and maybe insurmountable barrier for new users of the cycle hire scheme. And so my question and observation comment to members is, what assurances do we have as a city from County Council that new routes will be established to support the adoption of trips by bike? Bike Worcester have been campaigning for years for better cycling infrastructure, and we're yet to make much progress. We hope that this scheme yields a new day for cycling in Worcester, but I'd love to hear from members and officers if we have that assurance from County Council. I will wrap up very, very quickly. I think that's all I needed to say, actually. I'll leave it for others. But as I say, if anyone's got any questions, please do get in touch. Thank you, Chair.
Thank you very much. Thank you for coming, and thank you for your enthusiasm and what you've done to Bike Worcester have done. Encourage cycling in the city. So item 4, minutes of the last meeting, which was the 17th of July. Go through them page by page, any or corrections. So page 1, page 2, 3. Thank you. So I will formally sign those off for the record. Which moves us on to item 5, Herefordshire and Worcestershire Integrated Care. Give us a small intro, Lloyd.
Yes, thank you, Chair. I won't say very much at all. I've put a light covering report together for members. The main point of that report was to introduce colleagues that we have sat around the table. I think we have one substitute, so it'd be worth colleagues just introducing themselves again. But it just gives some background to the introduction of the ICB. And as members will be aware, we have brought some reports through this committee over the last couple of cycles, just to try and introduce members to the concept of the ICB and the ICS. But I think I'll leave it at that, Chair, and leave it to the experts.
Thank you. And I'm welcome to our esteemed guests. I feel very honoured that we've got the most senior people from the health and care system for Herefordshire and Worcestershire and for our local primary services for Worcester City. So I think it'd be really helpful if you kind of introduced yourselves in turn and just indicate what you're responsible for. And you're going to give us a small presentation?
Yeah, we've got some slides. Yeah, shall I start then? So, I mean, thank you for the welcome. Very nice to be welcomed to a meeting like this in such a positive way. I'm David Mahaffey. I'm the Director of Strategy and Integration for the Integrated Care Board. And to my left, I've got...
Okay. What you need to do is... What do I need to do?
Oh, okay. All right.
Is that going to work? Okay, yeah. So no, thanks ever so much. Really great to be here. Sue Harris, Director of Strategy and Partnerships, and I'm from Herefordshire and Worcestershire Health and Care Trust, so we run the community and mental health service. Evening, everyone. I'm Linda Dando. I'm Director of Primary Care Transformation and Commissioning for Hereford and Worcestershire ICS.
I'm Dave McDowell, one of the PCN managers for Worcester City Primary Care Network.
Fantastic. If we could put the slides up then, please. Okay. So a couple of topics to talk you through this evening. I'll do a very brief update on the integrated care system generally. I'll then talk about a few positives and negatives, a bit of honesty around how health services are going at the moment to give a flavour of things that we think we're doing well and some things that we know we need to do better at. I will then pass over to Linda to talk about primary care, particularly primary care access, which we know is a big issue across the country. Linda will talk about that. David will then talk a little bit about some of the work that the PCN is doing in more detail, and then finally on to Sue to talk about mental health services. So that's our plan of attack. So if we could have the next slide, please. I've just put a few slides together. And we'll run through them in the order that they're there, but please do feel free to ask any questions as we go. I'm sure that people are familiar with integrated care systems. They were formed in July 2022, a new structure for NHS services. And we in Herefordshire and Worcestershire, so we cover both the counties, are one of 42 in the country. We're one of the smaller ones. I think we're the 6th smallest by population, which has some disadvantages, but also some, what we would believe, some significant advantages, particularly in our ability to build relationships with our local government colleagues, both from the county council and the district council. So we have participation in all the district collaboratives, for example. We have a relatively small number of primary care networks. Some of the bigger systems, like if you go to Greater Manchester, they serve 3 million people. They've got 10 upper tier local authorities, 10 health and wellbeing boards. It's so much harder to engage proactively in integrated care in that sort of system. So some advantages there from having a small system. Since our formation, we've published 2 documents, 2 significant strategies that you can see on the table, on the slide there. The first one is a 10-year strategy that we've developed with partners across the integrated care system, which is about prioritising the 3 areas shown there. Best start in life for children, living, ageing and dying well, and then preventing ill health and premature death from avoidable causes. So those are the 3 big priority areas that we've as a partnership, and that partnership includes local authority, the police, fire, education sector, voluntary sector, you name it. If those people have an interest or a role to play in improving health and well-being, then they're around that partnership table. The second strategy, or the second document we produce, is something called the NHS Joint Forward Plan, and that's a much more of an NHS-specific document where the ICB, 3 NHS trusts, and the primary care families across both counties got together and said, so how are we as an NHS family going to get to deliver these priorities? And that's what we've set out in the Joint Forward Plan there, and both of those documents are in the public domain. The big thing about the Joint Forward Plan for me is it marks a significant shift in the way in which NHS thinking is happening. So the NHS was formed in kind of 1948 to fix illness, to mend people who are sick. What we're trying to do with this Joint Forward Plan is really shift our focus to thinking more about how do we help to prevent illness. And local authorities, district councils in particular, with your leisure services, your housing, community services, that level of engagement that you've got with your population has a massive role to play in helping to prevent illness. So we're really keen to work with you to make sure that we can implement that priority within that strategy. The second area we call best value care in the right setting, and that's essentially just trying to make sure that when we do provide care to people, it's in the optimal care setting. We don't want people to be in an acute hospital bed when they can be in their own bed. We don't want people to be in a community hospital bed when they can be in their own bed. What we want to do is get the right care to the right people at the optimal time, because often it's cheaper, it's a more effective effective care for them, but it's better. People are more independent in their own homes. They've got a better chance of living longer independent lives if they're in their own home. Put somebody in a hospital bed, an acute hospital bed. There's a statistic that shocked me several years ago. I think I might get my ages slightly wrong here, but that would be my age reflecting that. But a 70-year-old spends 10 years in an acute hospital bed would suffer 10 years of muscle wastage in 10 days. That's the kind of level of issue we're talking about. So if we can prevent people needing to go into an acute hospital bed, and if they are in an acute hospital bed because their treatment's complete, can get them home more quickly, then that's the best outcome for them. And it's the best outcome for the taxpayer as well. Can we go on to the next slide, please? So in terms of a few positives and negatives, I thought I'd just share some reflections on some of the things that I think should be visible to the population of Worcester City in particular. So people may be aware that the new ED opened last Monday, £35 million investment in a fantastic new facility for the population. It's a very visible thing. Secondly, we've got some of the lowest levels of delayed discharges in the country. So we don't have as big an issue in this part of the world as other places have with people stuck in hospital trying to leave. And that's down to the good work of our local authority colleagues, whether that's the social care teams in the county council, or whether that's the housing teams working in the district councils. Getting people back out of hospital into their homes is a big thing for us. People will know that COVID had a big impact on the NHS and all of us indeed. I was talking to Councillor Lawrence just now about somebody who was waiting for a hip replacement since before COVID. I mean, COVID had a massive impact on waiting lists, and it's taking years to recover. I mean, just to give you a flavour, we sent a briefing note around with some of the numbers, which hopefully you've seen. But in the last 18 months, we've managed to reduce 78-week waits, which are horrendous, 18 months waiting for care. But 18 months ago, there were 1,425 people waiting longer than 18 months. In October, at the moment, we've got that number down to 85. We've got a lot further to go on that, but we're making progress. Our next big target is to reduce a year and a quarter wait, so 65-week wait. Then we want to reduce 52-week waits. And then ultimately, we want to get back to 18-week waits. That's where we were before COVID, kind of 90% of people being seen within 18 weeks. That's where we want to get to ultimately, but there's a mountain to climb to get to there, we'll be honest with that. Another positive, mental health teams in schools. In the last 18 months, we've doubled the provision and the supply of mental health teams in schools, and at the end of the Wave 11 expansion, there'll be 20 schools across Worcester City with a mental health team supporting the school teams. We've massively improved cancer waiting times as well, so you can see some of the stats I've put on the figure there. So 48% of people being diagnosed within 14 days now, up from 28% 18 months ago, and 70% nearly in 28 days, up from just over half 18 months ago. So that's a really important achievement for us, and we need to improve our cancer services and keep those improving. Stephen mentioned that he's a GP. He will be familiar with this. 100,000 more GP appointments across Herefordshire and Worcestershire since before COVID. 100,000. We've gone from about 450,000 to about 550,000 a month. I mean, that's a staggering increase. Yet people around the table, I'm sure, will be saying, well, why can't I get an appointment with my GP? The reason for that, massive increase in demand. It's not a reduction in the number of staff. It's not a reduction in the number of appointments. It's down to a massive increase in demand. And we'll talk about that in a little bit more detail. And finally, I can see Matt in the room as well, and Worcestershire Public Health, big part of this as well. The Your Health buses are now on the road. There's an artwork of one there, but hopefully you'll see the real thing driving around the streets of Worcester City fairly soon, taking health outreach and wellbeing outreach services into the community. So a plug, please, if you're aware of it, we'll find out more about it, promote it in your communities, and invite us into some of your most deprived communities where we can have some impact. That's the positives. From the negatives, we know that I've already mentioned getting an appointment with a GP can be difficult. We all experience it. I'm a resident of Worcester City. I share the experiences of other people. Talk about how we're improving that. We know we've still got a big issue with ambulance delays, handover delays, responding to 999 calls in the community. Again, big priority. And associated with that, we need to improve waiting times in the ED department. And finally, the other big one that stands out for me is the long waits for children's and adolescent services, which we know we need to improve. And again, Sue's here can talk a little bit more about that. But that's enough from me as a general introduction. I did go on a lot longer than I intended to, though. I do tend to ad-lib on these things. Sorry, Linda. So I'm going to hand over to Linda now, who's going to talk a little bit more about primary care.
Thank you. So I'm going to talk a little about how it is now, and David has touched upon some of the negatives that patients are currently experiencing when they try to contact their GP appointment. Then I'm very quickly going to switch to what's already started to happen locally and nationally because of the National Recovery Plan for improving access to general practice, because that's highly relevant in the context of local general practice. As David has said, and as the slide sets out, there are a lot of appointments being made available, but how those appointments are being offered in certain parts of the county and the country isn't fit for general modern healthcare. So first and foremost, it's important to point out here that the baseline, what the government and NHS England is using as a marker, is the National Patient Survey, which is undertaken every January on the previous year. So the baseline for the improvements that we're now looking at is 2022, published in 2023. It asks a lot of questions, but it really tries to understand from those patients who return their survey what their level of satisfaction is, what their experience is in trying to get an appointment. And it's those two key questions really that have really got NHSC and the government in particular worried. Hence the introduction and production of the national plan that I've just mentioned in May of this year. Could you turn to the next slide, please? So the here and now from that survey that I've just mentioned shows that as a county, as a system, we are actually the 6th highest in the country regards patient satisfaction and experience. But there is huge variation. And it's the variation that the national plan and ourselves, and David will speak about in detail, that we're trying to tackle. So when you look at that very stark figure there, 54% said the experience of their last appointment was good or very good. The national rate is 54.4%. So it's not great, is it? It's not good at all. And this is the effort and the work that we're now trying to put in to improve that. What's poor, as far as Worcestershire City is concerned, is the experience of getting through on the phone. So if I can touch on now the National Recovery Plan, there are some really important changes here that patients in particular need to be made aware of, because how we as patients access our practice in future is going to change. And it's going to change because at the moment, when David talks about those 100,000 appointments that GPs did see, those people that GPs did see, were they the right patients? Who knows, because it's a free-for-all. At the moment, it's an absolute free-for-all. You telephone, you hope there are some appointments available, but there aren't always. Then you put into the next day, or even within the next fortnight. So the National Recovery Plan, the summary of which is attached, seeks to do a number of things, and they're critical for all of us as patients, for us to start to see the results of those. So first and foremost, the government and NHS England recognise that 40% of all patients who are trying to make an appointment and get an appointment with their GP didn't need to see a GP. So the workload coming in to GP practices is such that we now, as commissioners, have to work on 7 different services, those that are most commonly sought from the GP practice by patients, to make sure that patients can go directly to those services. That's one important piece of this plan. The second thing is recognising that community pharmacies are skilled, trained, expert in 7 services, that if those patients didn't have to go through a GP but went through their pharmacy instead, that would also reduce telephone calls, throughput, etc. So that's really important to get right. The other elements of the plan, as I say, the summary is in the annex there, are of a similar theme. There are all sorts of statistics in this national plan which talk about the people who don't need to see the GP, making sure that that senior, very expensive, sorry Stephen, senior clinical decision maker is available on the day for those who are most fragile and ill, severely, any other way. They can be seen there and then by their GP. So to do that, the whole way of accessing general practice needs to change. And NHS England is providing a considerable amount of funding to support that change. So already we have received funding to change the telephone systems in all GP practices throughout the country. That will do a number of things, not least of which is, if you are one of those patients who are hanging on and you're number 15 in the queue, you will now get a call back. That's just one of the functions that this new telephone system will provide. The other things that are being put in place, and there's good participation from Worcester City practices within these, are some transformation programs. So NHS England is running programs so GPs, practice managers can exit the surgery for 26 weeks and think about what changes they need to make to their appointment systems. How can they better understand demand and capacity to make sure GPs, etc., are there when patients need them to be there? That is the skeleton, if you like, of the National Recovery Plan for Access. What PCNs have to do, in addition, is to develop a plan for their PCN. So David, with the CDs, clinical directors in Worcestershire, have developed a plan which sets out how it will improve on 3 things in this 12-month period in which we're operating. Patient experience, access by telephone, friends and family test. So I'll pass on to David now so he can talk about their plan and how we will see improvement with the variation that we've just shared.
Thanks, Linda. You can see the stats through there in front of you. So we know as a PCN that we are falling slightly below the national average. We completely get that and we completely accept it. We actually knew it before any of this data came out because we were following ourselves. What we've done with our plan is we put a massive emphasis on not running before we can walk. So things within primary care and within general practice have been the same for a long, long time. So for somebody like me to come in who wasn't NHS before and all of a sudden go, I'm going to rip up the rule book and we're just going to change everything, lose the confidence of the practices. Once you lose the confidence of the practices, you also lose the confidence of the public. So it was important that we came in. Linda's right, we have changed the phone system. We've went through a massive infrastructure change where even things like Wi-Fi in the practices is now all been updated. Workmen have been in for about the last 8 weeks doing it, that's how I know. All the phone systems are now in place. So the next thing for us to do is start to put reception staff, the admin staff, the GP, everybody that is going to be in that practice on a daily basis, through some level of training that they actually understand what are the capabilities of this new phone system that have came in. And it's not just that we're then just going to throw money at a phone system and then just leave it. We want to get the best possible thing that we can out of it. Now in place, training starts, we know that within the next sort of 6-12 months, very, very different. The one thing that we can say about Worcester City in general and the practices, the amount of work that has went on is, you see that the PCN on access by phone is below, but you can see whenever it comes to overall satisfaction, people are pleased with what they're getting from their GPs. They're happy whenever they go in there that they're getting what they need to get. The problem they have is getting in there. Next slide, please. So, as a PCN, we were formed in 2019 by the 10 practices within Worcester. You'll see on the board behind you, the map is of where the 10 practices are. We are a big PCN. PCNs are normally sort of anywhere from 15 to 50,000. Worcester City, circa 130,000 patients. It is a big, big PCN. 2019, Dr. Berger was clinical director. She came in with she knew what she wanted to achieve. She really, really did. So, unfortunately, at that point in time, pandemic hit. That slowed the rollout of primary care right down. It really did slow it down because it was all hands to the pump with the vaccine rollout, COVID, everything else that was going on. Only now are we probably starting, over the last 6 months, to see some form of normality returning. Okay? That's how long it's been. And even now, we're still out doing COVID vaccinations. We have, I can tell you now, we've already finished the care homes. We're about 80% through doing the housebound patients. We're flying through COVID as things stand, but we're still then seeing that. What Dr. Berger wanted to achieve, which is where she brought me in, was to build a PCN that had services on offer that didn't rely on a GP. That's what we wanted to achieve, was take the pressure away from the GPs, offer services that were there for the population of Worcester. We didn't really care whether it was what NHS England wanted, what everybody else wanted. We were doing it for the people of Worcester City. That's what we were doing. We were following the data. We were seeing where we were at, and we were saying that's what we need to deliver. So we set up an acute visiting service. Acute visiting service is all about, normally, call would come in, housebound patient, GP goes out. We went out and recruited 10 paramedics. Now, call comes in, paramedic goes out. GP doesn't have to leave. He can carry on, or they can carry on seeing surgery. If needed, the GP is on the end of a phone for that paramedic to answer any questions that they may have, or they're on the end of a phone if we feel they really need to go out. We brought in a primary care mental health team, an overflow hub, dietary, first contact physio, microsuction is Councillor Denham's favourite, because if you go to get microsuction privately, 85 quid. Take yourself down to Specsavers, pay 85 quid. Most city PCN, it's obviously free. So we invested heavily in bringing in the machine. On nearly 1,500, just under 100, 12 months, just over 12 months, which is good going. Women's health, we employed a health inequalities nursing team. We have our own wellbeing team, so social prescribers, lifestyle advisors, health and wellbeing coaches, care home team, and probably 6 or 7 other services that we also have going on at the moment. Next slide, please. So, some of the projects that we've been working on lately is our health inequalities nursing team, headed by our nurse manager, Leanne. Whenever we looked at the data, we realised that actually cervical screening in City was quite low, but it was quite low within a certain population. And that population was those that lived in areas of deprivation and working mums. So everybody else that fell outside that was all right. We were hitting it thereabouts within the targets. What we then decided to do was set up cervical screening drop-in clinics. So we approached a couple of the practices. We went in on a Saturday where they opened the practice at 9 o'clock in the morning. We went through until I think it was 3:30 for the first one. On opening the door at 9 o'clock, there was a queue outside. People who went to drop kids off at football and rugby and hockey and whatever else, and they'd pop down and to go and get cervical screening done. What we really wanted to do was have a space there for cervical screening that weren't going to be under pressure to come in and get your smear done. It was about coming in and could you get the education piece behind it as well. You know, explaining how important the HPV vaccine was, having that little bit more time on a Saturday to sit down with somebody and have a conversation. Cancer care coordinator was there, and a couple of other care coordinators, Leanne and 3 or 4 other nurses, some HCAs were there. So there was loads of people there to be able to answer questions and make women feel comfortable whenever they come in. So there was no rush. Sometimes you come in on Monday to Friday, proper grind, you know, it's 20 minutes in and out because it's just a busy, busy day. Whereas this was about taking the time. So January 2023, we have the start of our Saturday drop-in smear clinics. That number's slightly wrong now because we had another one, and I actually think there's one going on as we speak tonight. It's up to around about 450. August 2023, we had our first late night drop-in. So as you would, Thursday shopping, late night shopping, we decided that we would open up one of the practices from 5:30 to 8 o'clock. So we would just extend the opening times, and it was going to be for cervical screening. To date, we've had everything from working mums, refugees, homeless ladies, ladies who work, ladies who don't work, single mums. We've had everybody you can think of come through the doors. And the one thing that I know Leanne and her team have been really, really proud of is they've turned nobody away. So whether they're a resident in Worcester City or they're not a resident in Worcester City, or they're registered with a GP or they're not registered with a GP, they found a way to make sure that that's getting done. Yeah. And that was the important thing. Next slide, please. Some other things that we've been working on. We have just launched a smoking cessation group. I, for one, was not the biggest fan of this, and I have been pleasantly surprised that since they launched the sign up for it, sign up's all done online. Go on the website, you can sign up on the website, or you don't have the phone, you don't have to do anything, you sign up. Been way over 100 people have signed up in a matter of weeks. Like, they opened it, and I think within 2 or 3 days there was signed up for that. First one's already been done, 4th of October, and then we run every week for 12 weeks. So yeah, you know, anybody that wants to know that, come, let me know. The other one that we've done, Menopause Cafe, located at G&T. Anybody that doesn't know where G&T is, it's a cracking little coffee shop in the town centre. It's led by our clinical pharmacist and care coordinator and a couple of other sort of healthcare professionals, female healthcare professionals. And it's an opportunity for women that are going through that to just go in and discuss what is going on and understand that they're not on their own. The one thing that I was actually quite shocked about, obviously not understanding what's going on, was how thankful people in Worcester City were for this cafe that had sprung up before it opened at 12 o'clock. You know, we're in there at 10, they can go in and have a cup of tea. Other females who are going through the thing. Some of them have turned around and said to Becky about, can they bring their partners along? Partners can learn about what's going on as well, and it has been a huge success. Then we launched an Overflow Hub. Overflow Hub was designed that everybody knows, Linda's just spoken about it, David's just spoken about it, that mad 8 a.m. rush every single morning. Mondays, carnage. Monday mornings, you know you're getting it. This overflow hub was designed in the city that once practices reach capacity, or even before they reach capacity, it's about making sure that you put the correct patient in the correct room with the correct clinician at the correct time. Not just automatically going, you're going to see a GP. Somebody has a sore shoulder, they don't actually need to see a GP. They probably need to see a first contact physio. Most people say, but I want to see a GP. You're going to have 2 appointments then. So you're going to go and see the GP, who's then going to refer you in to go and see a first contact physio. So you may as well just go straight to the physio. And that's what we're trying to achieve with overflow, is that if we feel there's a better clinician that can do that job at that time and make it easier for the patient, it's not meant to be easier for us, it's easier for the patient, we get them in to see that clinician as quickly as we can. The waiting time for overflow between that patient phoning into the practice and getting some form of appointment with a clinician is round about 4 hours. So they can phone in 9 o'clock, there's no appointments left at the practice, but we can get you one with our overflow team. It's probably going to be a telephone call. Is that all right? 99% of people are like, absolutely, that's all I want. That has been a massive, massive success, and it's offering roughly around an additional 2,500 appointments a month. Probably slightly. Next slide, please.
Okay. Thank you. So we're just going to finish off. It's going to be doubled up. Can everybody hear me? Yeah, so that's okay. So, I mean, this is obviously an extensive topic. I probably could have a whole meeting just covering all of the challenges, the transformation sector. I've done over 30 years in the mental health field, and it's never had the prominence that it has, and about that, the Health and Wellbeing Board priority. We're having much more integrated conversations around what we're now presentation demand across the board, and actually a system-wide approach. Got to think, right, okay, what does this look like? What can we do? I suppose I just wanted to caveat as well that we don't talk about physical health services in this way. We talk about stroke, respiratory, yet within mental health, we put them all under one banner and the nuances get lost. So just for completeness, you've obviously got the spectrum of services across children and young people, adults, older adults, you've got community teams, you've got beds, you've got specialist teams, perinatal, forensic. I think my observation has been that the system conversations, people often got very frustrated by what they saw as a lack of a mental response because they didn't. And a lot of people have actually said they're really very concerned when they see what you're saying. So the voluntary sector, my housing college, about self-harm, or that's a really scary position as an individual practitioner, and that will then mean that you go to look for support and then get very, very distressed when it might be there. So we've started to have very, very different conversations. Ones where we're really starting to say, well, available, where have we got gaps, what's changing? The pandemic, we've heard about the impact on primary care, more globally, okay, across all of the hospital services. The national evidence is that the shadow for the pandemic was going to last a long time and come later into mental health. And that's what we're seeing now. So just to give you one statistic, for example, we've seen the children and young people's eating disorder services by 300. That is, you track it back, there will be a correlation to what happened during COVID. David mentioned earlier about mental health support schools. Well, Worcester City is one of those areas that's got greater coverage, absolutely fantastic. That is about giving children the earliest opportunity to say, I'm worried about myself, I'm worried about my friends. It also gives the opportunity to say, I've started to see a change in this, get that intervention in it. What I suppose we're in danger of doing is potentially utilising COVID, and we've got to get into something which is more about what would work to build up mental resilience. Make sure then that when those specialist services are needed, they can respond in a really timely fashion. David mentioned about the waiting list for CAMS. What we're trying to do with things like the mental health schools is give earlier support so that when children who really do need CAMS, and that child who's developing very, very acute depression, they need to see CAMS quickly. At the moment, they're in a queue. So the big conversation is getting under the label, getting into what's presenting, being able for people what is commissioned, what we might need to dial up, dial down. There is national money coming in every year. It's ring-fenced. The issue we have is the workforce training and recruitment place with that. So the discussion we've been having is, could the voluntary sector, could we work with housing colleagues, could we think differently about build up the workforce? At the moment, the NHS. So I just wanted to just highlight as well some of this, kind of I often get asked what's available, and it's two things really which are accessible to everybody. If you look at Now We're Talking, if you go put that into a search engine, you'll come up with a whole entry point of resources and support. So you can go straight into talking therapies, for example, with adults without having to go through general. So then there's a whole raft of tools. You've got, for example, online counselling resource called Tooth. Again, that's a direct referral practice. And it's all there on the Now We're Talking website. We do a lot of promotion around that. We can never do enough. We tried to have a different campaign, men's mental health, just to keep that kind of access point as close to communities as it could be. In COVID, all ICSs had to develop a 24/7 mental health urgent helpline. I put the number there, obviously we'll be circulating. We're seeing the numbers go up for that every single week and month. Again, that is individuals, there's a different number for professionals. This is for individuals or family that are concerned and have got the individual wants to get. What we've also been doing in terms of upskilling and improving and increasing the confidence and competence across the broadest of the workforce, doing quite a lot about that training programme, whether that's mental health first aid. We've got the orange button scheme, which I've got my orange button on here, which is suicide prevention training, which is open to everybody that feels in their community they'd like to be more empowered to have those conversations. And we've recently developed a professionals portal, and that is dominantly designed for housing colleagues who in particular have helped us understand what their challenges are and what they think would be useful, and it's also available to our voluntary sector. We're broadening that out all of the time. The police have fed back, they found that very useful, and I think for us really it's designing that in so that it really then just links into what would that really need to look like for say. So next slide please. I often get told the mental health system is incredibly confusing. So what if you just push a few more buttons, I think you'll get all three up. I think so these are the posters that we've started to basically raise the profile on and make them available predominantly through the Now We're Talking campaign to all partners. And it's just to try and simplify the access points and to help people understand what they can do for themselves. So it's very simple in that, how am I today? I feel okay, I'm wobbling, I need help now. And it's just then to help people navigate. Some of the services on the more specialist end, you will have to go through general practice. But actually it's that I'm really concerned now today where we need the urgent mental health line better understood, better promoted. That is the area which obviously carries the most risk, and that is where we want people to get really. It is this amber ground where I think there's often some confusion around what's available, and that is where we can route people in. Website, and then some parts may go through to general practice, but more work's happening with general practice to do what David's described, is to see a mental health practitioner first, not to have to go through a GP. Again, that's where I think we've got the opportunities to integrate and do more of that. Say I could have done a whole couple of hours. I'm very passionate about But that's pretty much us to the end of the presentation.
Yeah, I won't say any more to wrap up, Lynn. We've taken enough of your agenda this evening, but thank you for having us here. I'm happy to take any questions.
Thank you. You've covered a huge amount of ground and given us a lot of information of the health service. People's health needs are incredibly complex. So well done for sort of a taster and giving us some really useful information. Yeah, open the floor to questions. First, Elaine?
I've got a few questions, but I don't want to be greedy, so I do one and then share it around a bit. Or shall I just rapid fire them? Thank you. Thank you so much for coming and for the detailed report that came with the agenda as well. I've got a couple of questions, if I can, just picking up on maybe some more of the detail around the mental health provision in schools. So whether you could elaborate a little bit more about actually what are the access arrangements for the mental health provision for children and young people in school, and what level do they need to be at before they can access it, and once they've accessed, what they're able to achieve? Is it a one-off session and some self-directed support, or is it an ongoing package of care from the mental health?
Okay, so the mental health team in school is recruited, are trained specifically. There's an allocated, yeah, probably more than some of the bigger ones. Effectively part of that school too. Got a dual role, one which is they can take up from anybody. Doesn't. Also a piece that runs alongside that. In the pupils. If there's a concern, those so the way that they work is that it's a trained workforce. So as a result, they're very active posts. It's one of the few parts. Very stable. Now that actually works. Sounds going out to its schools. But yeah, it's effectively rather than a out.
And is there any upstream embedded within that team?
So the district collaborative months ago, more funded a children and young person. Accurate
number. And again, on maybe a similar theme about the Your Health buses, which are fantastic, but I'm again interested in what sort of community engagement there was to make sure that those buses are being used in
match demand for that question. But what I can say is that it's all very, work quite closely with the PC. They'll come to us and it'll be very much around what area do we think it would be better going to. We're all doing this together. That's the thing. It's a very collaborative approach. You know, it's not about an us and them thing. It's about a us, and it's about certainly within buying through the middle of the city is just getting into areas. The good thing about the buses is offer whatever.
I mean, the whole point of them really is about getting health and wellbeing services into the communities that don't find it as easy to access services as some other communities. The kind of local government and NHS looking at itself and going, how can we do this better than we've done it historically? There's no such thing as a hard to reach group. It's just a badly designed service. If we can turn that on its head and make it easier to access them,
Search session with mental health professionals Thursday, and that came from the communities themselves. And were you there?
Yeah, it was really
Are you OG?
Yeah.
Oh, so, if only I'd known. But yeah, no, so brilliant. And my third question is, we talked about smoking cessation a little bit, but I was wondering if there was any plans around tackling vaping.
Currently, no. Yeah, is my honest answer. It's sort of, again, it's a workforce thing, and we have to, don't want to use, where is that priority right now? And that priority right now was definitely in that sort of, it's actually in the cohort, age of 40, would you believe? That really getting in there and just sort of getting that offer out in the next 6 months.
Yeah, thank you for the presentation. Just a short question. How many dental practices are currently accepting new? What is average waiting list for new NHS patients?
that might be one we need to come back to you on. Don't know the numbers off the top of my head, but if anybody does, then Linda might know.
We do know that we've recently been successful with NHS England in commissioning two new practices, which will be based around this area, very close to this area now that the procurement has completed. We've only recently taken on responsibility for dentistry since July, but we're absolutely now trying to map out what's there, what isn't, and how we need to change our approach to that taken by NHS England to attract new dentists in with greater flexibilities, as well as retain those that remain in the NHS. But yeah, happy to come back at any time with the details of the new services to be provided and what our overall approach will be.
That is a really much needed service within Worcester City. It feels as though if you aren't already in the privileged position of being an NHS, virtually impossible to find. Yeah, it's quite high on the issues that people come to us as council. James?
Chair, thanks very much. Just to return back to the point that Elaine has spoken about, I'm particularly interested in this question of mental health awareness, particularly amongst those people who live in deprived communities. Those people who don't, and forgive the simplification of the question if you like, but they have the support networks to some extent. They maybe have a higher degree of confidence. It's reaching to those people who are don't have that awareness of what the support networks they can access, particularly amongst young people. There is again, I'm simplifying, perhaps overly so, but how can we be sure within the scope of the resources that we have available that we are really, reaching those young people? And if I could throw the supplementary in as well before you answer the question, what level of scrutiny is available to you guys as you go forward to say, either this particular, avenue, if you like, is working, and perhaps, where you might need to correct? Do you have that kind of data flow, as it were, that gives you that ongoing sense of what you're trying to achieve?
and work in progress, we've got some examples in mental health delivery where we do some of this very well. So we've got an early intervention diagnosis service. It works between the ages of 14 to 55. It uses prevalence and data to track people most at risk of developing. They are often into more deprived communities, and the teams are out there building up networks and basically putting out a radar, if you like, to make sure as soon as possible you can, and all of the evidence, if you get some an illness like early, you can keep people in family circles, you can knowledge, you can ensure that they go on to work and don't need to. So, but we don't work in other areas of mental health. So some of our other areas, for example, talking date has been are more able to pick up the phone or go on the internet, then probably access it readily. That's the change that we're making, the way in which we're working. David earlier said this is changing, you know, the how we do things. So some of that has absolutely got to be underpinned by data, and we know again that talking therapies predominantly is not accessed elsewhere. Probably would benefit from some sort of psychological intervention. It may not be this psychological intervention, something that we need to build together. And that's where the district collaboratives come in for me, is how do we get that data and stay agile with it and test and learn and go back and critically challenge each other. Because actually some of this is about the NHS monies potentially doing things with the voluntary sector, maybe providing a more trusted access point or a non-medical support offer for mental health. So that's the space that we're in with the district collaboratives, and that's the piece for me. We've got opportunities because we are still receiving more money for mental health. We've got the workforce challenge making it anyway, and then we have the opportunity to design in what's needed and go back and check. So I could give a number of examples where I think we're really targeted and we do that well, but I've also got a whole swathe of services that I don't think work like that at the moment.
Thank you, Lynn. And thank you very much for a very interesting presentation. Sorry to return to dental services, but what I was wondering is it possible, you've got that fantastic van coming, is it possible to get any form of mobile dental surgery which would tour the city? Not just emergencies, preventative, but checkups to go to the deprived areas, and also just maybe to schools or something like that on a rotationary basis. And I'm very pleased to hear that we've got 2 new dental practices coming. Will they have a flexible list for emergencies or overflow like you're offering with the GPs? That sounds like an excellent service. Would they possibly have capacity to take people in? Haven't been seen. That's question 1.
I think that was 2 questions. The first part of the question, I think I look to Matthew as well. We're pretty much open to, you know, taking the right service out to the right community. We've got a facility that can do that now, rather than a fixed building in a fixed area that people have to come to. So I think we would look to work with communities and get the right service. Certainly wouldn't rule anything out.
Yeah, thank you. That would be fantastic. And the other one is inoculations. A lot of people, I mean, we're aware of people who are anti-vaccines, and that, I think, affects people's long-term health. It's all right to choose that for yourself, but if you're choosing that for your child, as they go into young adulthood, as they maybe become parents themselves, they're putting themselves and their future offspring at risk. Is there any form of outreach awareness service offered to young people so that they may choose to take that step themselves to provide their own inoculation, take control of their own future health, even if it's something that their parents haven't?
It's challenge, and it's became more of a challenge COVID, to be brutally honest. I think there was a lot of vaccine hesitancy as we went further through COVID. I think there was also a lot of vaccine fatigue as we came through COVID. I know that as a PCN, we're having discussions all the time, but what is the next step for us? That is something that is very currently very, very practice-led. So the practice nurses will put on, right beside my office. So. And it's more about now, I think, every service that we offer, and I don't want to keep going back to it, but I think that sort of drop-in type service is probably the way we're going to go with more and more and more services, that you're never going to have that drop-in around, never going to have that drop-in around an AM, never going to have that drop-in around mental health. Things like cervical screening, like prostate cancer or bowel cancer, or those things where we can just do a test or we can just give a vaccination, why not have it as a drop-in clinic? But again, a lot of that boils down to staffing, a lot of that boils down to estate, a lot of that boils down to with which have the location and we have the staff before we go out and deliver.
Thank you, Chair. Thank you for your presentation. My question is about neurodivergency in adults. I know quite a few adults in Worcester City, including myself, that have been on a 2-year wait list. I just wondered if you could give any more information.
Yes, I mean, there's been quite a lot of national coverage as well. So, we have got a very small diagnostic service. So we're doing across the system how we might shape that pathway so that people can get. Some of that is almost post-diagnosis waiting. You might then helpful that would be available locally. There's some regional work going on as well about whether we might be able to pool some of our specialist capacity to potentially assessments. Just by sort of way of giving you some sense of the scale, at one point last year, it was a so we're really having to think very differently about. Obviously, that's then also. So I think as I sort of stand here around the system decade, this is the one we're going to have a fundamental. What is it? Early, and then how are we going to make sure we don't end up with that sort of access? We are missing opportunities.
Yeah, just a simple one really. Obviously, the Integrated Health Board has taken over from the Worcester Clinical Commissioning Group. Can't say that. How many non-clinical staff have you got now versus the previous regime?
I can't give you exact numbers, but what I can tell you is that the numbers of staff since CCGs were formed in 2012 have reduced every year because the government set something called a running cost reduction target, which ultimately results in the numbers of staff being reduced. In the coming 12 months, we need to make further 20% reductions to our running costs, and the following year we need to make another 10%. So given that where we started 18 months ago, we're already lower, we're going to be 30% smaller in 2 years' time than we are now. So it's quite a considerable change for us.
The austerity challenge. We were on quite a high about all the wonderful things that you're doing, and then the reality of trying to do it all with less. And I've got 2 questions to pick up. So actually kind of following on from that. So as a district council, we absolutely know in terms of health inequalities, the bigger issues are around, housing, deprivation, employment, and so on, and that have a huge impact on people's health. um, and know the benefits of participating in a partnership, working and trying to improve those things together. It was a kind of wake-up call for us, I think, as a council, with our budgetary challenges of looking at what are mandatory services that we have to provide and what are discretionary. And I absolutely challenged officers because, to my surprise, despite district councils being in the health partnership system, the legislation didn't actually make it mandatory for us. So it's not statutory. We absolutely acknowledge the value of it, but the amount of officer time when our budgets are stretched, where is there a resource? How do we get kind of the resource post-COVID? Because let's face it, there is still some kind of COVID money that's greasing the wheels, for want of a better description. How can we kind of maintain the level of partnership working around it?
Yeah, I mean, it's a really good question. And you're right to point out that when it came to forming integrated care boards, there wasn't a statutory requirement for district councils. It was very much aimed at the local authorities that provide public health and social care functions. But what I would say is we put as much emphasis into the district collaboratives, the Integrated Care Partnership Assembly, which all of the district councils participate in, and the voluntary sector. So for us, it's much bigger than just in Worcestershire, the county council that's the key partner on this. When it comes to the resource question, I would love to be able to say I've got a pot of money waiting to dish out to help you fund leisure services or some other service. But the reality of it is we're a health system that spends £20 million more than we're allocated by government, and that pressure gets harder every year. So the NHS finance doesn't work in the way that local government finance does. We don't have reserves. We have to go cap in hand to NHS England, who have to go and ask the Department of Health for funding to fund overspends. Last year we overspent by 14 million. This year our plan, it's horrible to say this, but our plan is to overspend by 20 million because we don't close the doors. If people turn up in A&E, if people phone an ambulance, if people go to their GP, if people come to mental health services, we don't have the mindset or the mentality or the mechanisms to close our doors and say, sorry, we can't help you. So that inevitably drives overspends. We need to find a way of breaking that cycle. And for me, breaking that cycle is, as I said in the Joint Forward Plan, moving away from treating the impact of illness, find a way of being more effective at preventing that illness. But the reality of it is, and local government finds this as frustrating as the NHS does, I'm sure, that often early help, prevention, early intervention are things that aren't statutory functions. And they're the first things that get cut away at when trying to face budget pressures, and we've got to try and prevent that from happening. Again, it's happened in the past and we've got to try and prevent it happening again, to give us all a fair chance at making a difference.
And my other question is a resident that in fact contacted myself and Atif, so a resident of ours. And as people come to us with a problem because they don't know where else to go. And actually, and we try and help and can't always. And this is about transport, hospital transport. So, within the acute sector or within healthcare, within the system, there are, services moving to particular hospital sites, which is efficient for the services, efficient use of expert time, clinical time. But the reality of access is really challenging. So this is a lady that lives in Worcester City that's got an outpatient appointment in Bromsgrove, not eligible for hospital transport, so was told to use community wheels, but the timing in which they will work, so they won't they won't stay late. They have to get back to base by 4:30, so she couldn't get her appointment. A taxi would have been £38 pay. What is she supposed to do? You know, not everybody has a friend or a relative that can work and give them a lift.
It's a very good question, a very good challenge, and one that we debate quite frequently. I would add, just to your opening point there, it's not just about the efficiency and the clinical convenience, it's actually about effectiveness and safety of services as much as anything else. So a lot of the centralisation of services, as they've been called, over the last few years have been about making those services safer. And if you've ever been in a position like I have with one of my children, who Karen knows, you want to be in the right service, not the service that's closest to you. You want to be in the safest service, the one that gives you the best outcome, not the one that's most convenient. And that's a really difficult trade-off for us to get right. But in saying that, we need to look at how we can make those services accessible for that lady. I've said there's no such thing as a hard-to-reach group, or it's about the service design. So maybe I would always encourage services to have the conversation. Do they really need to go to Bromstead? Does it have to be a face-to-face appointment? Could it be something that could be dealt with through other mechanisms? Is there another route that we could go through to get that lady the care she needs? It will always be a challenge, but we're open to exploring different avenues to try and resolve those challenges, because that's what we're here to do.
Very much. I'm not sure you quite solved her problem, but yes, it is a very real. And I do think, sometimes the the missed appointment, actually, it's because people physically can't get. I mean, she's delayed her appointment. Diabetic retinopathy.
The other thing I'd say is that there's a really big role for the voluntary sector here. So you mentioned community wheels, but actually supporting the voluntary sector to create the means to be able to support residents to get around is one of the answers. Because we, as an NHS, we can't put on the services if she doesn't meet the requirements for patient transport. Then that's our option exhausted. We need to look at other options, and often working with the voluntary sector is the best route to go, and we would certainly be open to that.
Also, I have had this discussion with somebody else last week, and I think there's also the thing of, if we've got the likes of community wheels who go from 8 AM until 4:30, that's amazing. But actually, as healthcare changes, it doesn't stop at 4:30 anymore, and I actually think there's a much bigger discussion around, is 4:30 the right time to be returning to base, or actually is 7 o'clock the right time to be saying that you're going to base? I just think it's a much bigger conversation than just 4:30 and pass it on to somebody else, but it's not.
Thank you. Put transport on your agenda. Thank you so much for coming and for answering all our questions. It's really appreciated and very grateful. We have our next agenda item is a specific project within within our local health services, which is very much a joint project. Are you introducing Lloyd? Oh, right. Over to you, David. Warmth on prescription.
Yeah, just go on to the next slide for me, please. You're going to have to listen to me now for the next 10 minutes. The one question that's been asked loads since warmth on prescription came in my general direction was, why warmth on prescription? So what I've done was I've got a few stats. Basically, the NHS spends 1.3 billion every year treating illness associated with cold homes. The cost of living crisis is seeing record numbers of UK residents struggle to pay their energy bills. We're facing a growing fuel poverty crisis. This will impact people from all walks of life. Millions of people who suffer from health conditions such as COPD, cardiovascular diseases, asthma, arthritis are at even greater risk. Those living in cold homes put residents like this at greater risk of harm. Shockingly, around 10,000 people die every year in the UK as a result of having a cold house. In Worcester, between December 2021 and March 22, more than 2,000 people with similar health conditions as what I just discussed on the last slide were hospitalised for emergency treatment. That cost the NHS around about £6.5 million. £6.5 million. That's primary care, secondary care. It's therefore easy to see how combining energy and health can make a real difference in safeguarding our frontline services and supporting the health of individual residents. Next slide, please. And the next one. Next slide again, please. That's it. So the project operates in partnership with the NHS. We don't actually head this project up. We were just brought in as go and find the data and tell us which patients we're going to, which people in Worcester we're going to help. That's what we were brought in for. No NHS funding is used to pay for the energy bills. The funding is derived from the UK government's Housing Support Fund, which is allocated to county councils and unitary authorities across the country to help residents with the cost of living crisis. Next slide, please. So, how it's going to work for us. GPs, social prescribers, fire service, and a couple of other people that we've sort of kept very, very small. It's been discussed a lot at District Collaborative over the last sort of 6 months of how public do we go with it? Do we not go public? What do we do? You'll see in the next couple of slides, it's a very, very small pot of money. So what we're actually doing is we didn't want to go public. We need to control that because there's going to be hundreds, if not thousands, of households within Worcester City that could use this pot of money. We don't have that much. So it was keeping it very, 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 very tight. PCN have went out and identified people that we think are really going to benefit from this. Definitely within the areas of deprivation, sort of IMDs 1 and 2, mainly IMD 1. Eligible patients will be referred into the scheme. They're visited at home by an energy advocate who carries out an assessment to determine the level of support they could provide and offer interim energy advice. I've questioned the energy advice, so that could be anything from why have you got your heating set at 24? Or why have you got your heating set at 16? Why are you not putting it on this? And just sort of going in there and looking at, you know, have they got draft excluders in the house? Are the windows properly closed? Is there anywhere that sort of heat that they can get, is there anywhere it can escape from? So they go in to do a full assessment. Financial support will be paid directly to the energy supplier, providing peace of mind and fundamentally keeping patients warm and well in their homes. This is not for items such as electric blankets and heaters. As soon as somebody heard that this pot of money was going to be there, the following day my inbox literally filled up with, can you go out and buy a load of electric blankets and a load of heaters? And the answer is no. And it's not a self-referral scheme. Again, it was a very small pot of money. If we start to bring in a self-referral scheme, again, discuss the District Collaborative, who controls that, who says yes, who says no. So it's very much, this is what we've got, and we've got to go and find out what we're going to do with it. Next slide, please. So this is what, don't quote me on these numbers, this is rough. Okay, the final meeting is on Thursday, but it's going to be round about this amount. So it is £50,000. Acton Energy take a delivery fee of just over £5,000. The PCN aren't taking anything, so that means that the total amount left is around about £45,000. They estimate that each household will get about £1,000. So what we're basically saying is that we've got enough money to help 45 households in Worcester City. That's what we have. And even if we went £500 per household, we're still only going at 90, so we're still at less than 100. Hence the reason why on the previous slide we were saying it's not self-referral, it's not just a free-for-all. We've got to control it as much as we can. Next slide, please. So what we have decided to do as a PCN is identify the first cohort of 40 patients. We want to try and keep back a small pot of money in case there's a family that has an emergency over winter, or we could go out and spend this money tomorrow. We could genuinely go out and spend it tomorrow. What happens in January? What happens in February? It's still cold. So it's about keeping just a small pot back for those that are going to be really in need. Once Acton Energy have processed the first batch of 40 applications and calculated the energy payments for those, we can then have a look and see how much of that budget is left. So, like I said, it could be £1,000 per household. Somebody might only need 400, somebody might only need 600, somebody might actually need slightly more than 1,000. So once we get those first 40 out of the way, we'll see what type of money's left and what we're going to do next. Worcester City plans to include the option of a buffer, which is what I've just said, for any critical cases identified during the winter. Next slide, please. So the big challenge, you just keep hitting, and a couple of other bits will come up. So, what we had, again, going back to District Collaborative, because this is the power of the District Collaborative, we can have these conversations. It was, how are we going to figure this out? We've got 50 grand. How are we going to figure out where this 50 grand is going to go without it becoming a free-for-all? We started looking at some data. The PCN holds all of that data where we can dig really, really deep. So, what we did know was that, as you can see, we started running a series of searches. So whenever we ran the first search, we were able to say that within Worcester City alone, those people on the COPD register was 2,302. Definitely isn't going to fit into 50 grand. Those people with a comorbidity. So comorbidity is somebody that has something else as well as COPD. So we included asthma, dementia, depression, diabetes, hypertension, peripheral arterial disease, coronary heart disease, atrial fibrillation, chronic kidney disease, and stroke. Once we've done that, we then found there was still 1,929. Still not anywhere near it. So we then looked at those people that had hospital attendance last winter. So between December and February 2023, and we got it down to 148. 44 of those lived in IMD1. Straight away, that was our first cohort. Those people in IMD1 that have all of the above, 44 people. So we'll reach out to those people. Social prescribers are going to start doing this, reaching out to those people and seeing who needs that level of help. If all 44 of those say yes, see what we can do. If they don't all say yes, we'll start moving into IMD2. If they don't all say yes, go back to IMD1 and we'll see if anything has changed. What we don't want to do as a PCN is start working our way down the IMDs. So we don't want to go IMD1, IMD2, IMD3, 4, 5. We want to stay in that sort of 1 and 2. That's what we really want to be. So if we've got to chop back and forth for a bit, people's situations will change. Some people are just proud. And the first time they'll maybe say no, but it might be that it's not a phone call they need, it's a knock on the door. Then we can have a different type of conversation whenever we do it that way. Next slide, please. Done. There you go. Just as a stat for you, so in IMD1, there's 451 people in IMD1 alone that have COPD. So even if we're saying £1,000 per household, fucking 450k. So we're 400,000 short just from helping those in IMD1.
and that's how small that pot of money really is. It's tiny. So yeah, happy to take any questions, but yeah, it was just a quick overview.
Thank you very much for explaining that. I think as it is a joint project, we will be, as it rolls.
Yeah, and we can report that back through the district collaborative highlight report that we bring twice a year.
Thank you. I've got Hannah first.
Thank you, Chair. Thank you for the report. I'm finding it quite difficult to express just how angry I am that this government has put these residents in this position. Absolutely not at fault. No. It's the government. And my question is actually from Councillor Neil Lawrenson, who couldn't be here this evening. His question is that it will fund around 45 households. What support might be available once the fund has been spent, please?
Not a question for me, unfortunately. I'm there to find the numbers, identify the households that we think are most in need. Once Act on Energy have been in and said, you know, that person needs 600 quid, 700 quid, 800 quid, whatever it may be, I'm done. I've got my piece.
I was just going to say, Chair, there are a few schemes that are bobbing about that can support people. Types of measures. Improve energy efficiency and the outcomes of health. And that's something that we do report through Environment Committee, part of the Green Homes grant work. But again, if members want a briefing note, all members want a briefing note on types of support available, that's something we can put together and put out on Wednesday.
The one thing I can say is we've now identified this cohort of patients, as in from a primary care perspective, we've identified these cohort of patients. So what we've asked the social prescribers to do is, so they're going to make contact to see if the person wants into the scheme. But what we say to the social prescribers is we want you to contact them again 6 weeks later, just to see, is there something else that social prescriber can do? Because you've possibly opened up a level of dialogue with somebody who might not have been in dialogue with you before. Even, you know, looking at loneliness, social isolation, other mental health problems, whatever it may be. And then they're going to make contact again after 12 weeks. And if that is, then the social prescriber needs to signpost them in the other services. That's what they will do. But yeah.
Yes, I saw something on the news about this particular how it's being used to benefit patients side. So this scheme is obviously obviously it is a very limited resource. Obviously done well to find the most deserving cohort for this particular. Do you have any influence, for example, that people on this scheme will have cost-effective energy tariff? Because obviously, you know, different rates, and basically, as well as providing the grant, also to get them onto the cheap tariff as well. I think that would be a very, very shrewd thing to actually do, and also to look at their energy consumption, and if they've got, for example, things in their house that aren't necessarily for keeping the house warm, but are actually high energy usage, to actually advise on how they use the energy. Fundamentally, this money help people keep warm, basically, because keeping warm means it's about being healthy and about, you know, living, basically. I would say those are 2 points I'd like to make.
Act on Energy, who are the energy advocates for this scheme, I know for a fact that whenever they go into the houses, it is one of the many things that they look at is, and only from speaking with them, it was things like if they had, how energy efficient is the washing machine? Why are you using a tumbler? You know, all the little bits and bobs, they go in and ask all those questions and give, I think, is pretty good advice.
you know, I've sat and listened to them and went, okay, go home and flick that switch off before I go to bed tonight. I'm waking up in the morning, still only 2p less. But yeah, I think they offer really, really good advice. And one of the things is about energy tariffs, and there was talk about break clauses and stuff like that. So yeah, they seem to be very, very good.
Thank you, Chair. I think it sounds like a wonderful scheme on the surface, and it is something that would be really, but there's not enough. Is this kind of more of a sort of pilot to see if it would work? Are you looking to get figures back that would justify perhaps a saving within the NHS? So you could say, look, this works, this investment, and therefore maybe we could get a bigger budget for the following year. And I was wondering, will you be recording if these people aren't, say, living on their own, that there will be other people that might even be extended families benefiting from that, and perhaps that they could be included in the numbers, but a secondary, and see if you can measure any improvement or preventative measure in their health?
We'll follow the data, which is what we always do. So we'll see if it was patient A who had COPD plus asthma, we'll be able to track if that person last year, for example, had, let's say they had over the course of 12 months, 50 appointments, round about average. So they had 50, but between December and March, they had 25 of those between December and March. We'll be able to see if that had an effect. So we'll be able to see, did patient days come down year on year? So last year they had 25, did they only have 17 this year? Did they have 15? We'll also be able to watch hospital admissions. So were they in hospital 3 times, but this year they're only in once or not at all? Touch wood would be the ideal scenario. Whether it carries on, I don't know. I'd love it to. I'd love somebody to come in and say, here, have 450 grand. But will it? I don't know.
Yeah, just to add, I mean, the funding's coming through the household support fund. So as we stand here today, we don't know what the future of that fund looks like, whether it will exist come April next year. So we just don't know. The scheme was piloted in Redditch last winter, so there's quite a bit of learning that was taken from the introduction of that, but it's now been expanded across the county with 50,000 allocated to each district.
Thank you, Chair. I have 2 questions. One is in terms of your sort of search criteria, whether you have access to be able to cross-reference that patient population against their house EPC rating, to sort of like narrow it down to people who already have, Yes, okay.
I want to sound really, really boring whenever I say this, but if you look at atlas mapping, we can then use LSOAs, which is on EMIS, so we can use the LSOAs, which is basically your postcode. So LSOA is your postcode. We can use that to see the energy rating of people's houses. Pretty boring stuff, but we can do it. I've got it all mapped out, heat maps. It all looks really pretty.
Second question is about patient confidentiality. I'm kind of assuming that the reason that again is taking a lead for that reason, mechanism in place whereby before anybody else contacting them.
So first contact is made by Wellbeing team. So social prescribers are making the first contact, and the first question they ask them is, if you say you want to be part of this scheme, we are going to have to pass your details on to Act On Energy, who will do the next bit. So yeah.
Thank you very much. I mean, it absolutely illustrates, doesn't it, the scale of need of the potential cohort residents in our city who are at high risk of becoming ill because they can't afford to keep their home warm. And that's really frightening. You know, as councillors, you know, we're quite often privileged to see people in context in their home, which, you know, when you present to GP surgery or you present to other services, that isn't necessarily visible. And so, you know, there are many people in our city leading hugely diminished lives because they're not well, they can't afford the insulation. We are talking about tariffs, you know, a number of that cohort may well be on a prepayment for electricity and may also have equipment which needs plugged in, which has a further challenge. Well done for the project. We hope it's really successful. It would be great to roll it out wider. And again, it's an illustration, isn't it? You know, government announces a big number that will make a difference. £50,000 for Worcester for about 45 people. Thank you. Thank you for your time and thank you for what you do. Moving on to item 7, setting the budget for next year and medium-term financial plan into the future. I guess you're going to explain it all, Shane.
Thank you, Chair. Surely no further explanation is needed at this stage. For those of you who are new to this process, we developed this approach to budget setting when the committee system was established. And basically the system is that the council sets the budget. It does this by law and it has to do it in relation to setting the council tax, which is the primary purpose of the meeting. That must happen in February. Now it does that on the basis of recommendations made by Policy and Resources Committee. And those recommendations will be developed at the meeting of the 6th of February. Now, under the Constitution, the Policy and Resources Committee must consult widely on that process. And it does that in a number of ways, including an annual survey, which goes out to all residents around this time of year, or rather is online these days, and we have quite a number of responses to that. And also in consultation with local businesses through that approach as well, which is a statutory requirement, and through all the members of the council through these committees. So there are these committees now in October, and then the ones in January, which tend to be more formative in terms of what's presented through to Policy and Resources. And we'll talk more about that when we get to that stage. At this point, it's really just about information. It's just about kicking that process off and saying, well, these are the sort of areas of expenditure which fall within the remit of this committee. Have a think about them. Have a think about whether we want to shift resources towards something else. Think about whether there are things which should be considered here at this committee which aren't in our budget, which need to be brought in. And obviously, also think about, well, are there things that where we could reduce expenditure or become more efficient in the way that we deliver our activities. So that's the purpose of the meeting. It's not really a decision, sorry, not the meeting of the report, more for noting and consideration. And just to run through the highlights for you. Obviously, as you're aware, we're running through a process of making savings, increases income, and the contribution that this committee has made to that so far, under paragraph 3.5, the table there, you'll see under the column of health and well-being, there's 30,000 savings in non-statutory services. Now, don't be alarmed that this committee has a smaller amount than all the other committees. And that's because this committee doesn't have revenue budgets as such. It was created after only last year, was it? Or maybe even the year before the other committees. So we're building up a budget for it through the reserves process. So the things which fall to this committee are things like DWAS, which are considered about how we spend that. That's around about £120,000 in base budgets, although it was expanded to another 95 this year. There is also child poverty support reserve, which at the moment has 37,000 left, and that's being committed as and when it's required. And there was also, Tom's mentioned, the household support fund. So back in March, this committee considered the distribution of that element, which was 375, something, 337. there or thereabouts. So those are the kind of things, and we won't know, as Tom has said, until the early part of next year whether that's being repeated, and if it does, it'll come back here for consideration. Okay, so that one item, the savings in non-statutory services, was a principle of trying to use more of that external funding to support things like DWAS and transfer our own commitments to government funding that's coming through for the purpose. Now, we don't know at this stage whether that's continuing, so we will commit to the DWAS. We're not going to reduce that level, but in the event that we don't get the household support fund, we'll then need to make a decision about how we fund that, from reserves or from some of the means. So that will come back to us. So that's really just the purpose of it. The other two appendices are the capital budgets which cover all of the committees rather than just this one. And those are really setting out what the overall programme is. And there are a couple of areas which fall to this committee. I think David's going to talk about the Bike Worcester scheme later, aren't you, which is part of the Towns Fund work. So that's committed within the capital programme, within that big figure for Towns Fund commitment in this year of about 3 million. So those are, again, for information. If you want to know anything more about them, drop me a line, send me a note, talk to Mark Baldwin, let me know, and we'll do as much as we can to give you the advice and support you need, so that when we get to January, you feel capable and confident to input any thoughts and comments into that decision-making process. Hopefully that's clear enough. But any questions or clarifications, happy to deal with those. Thank you.
Thank you very much, Shane. Thank you. I mean, I think just to flag up, from my perspective, and having heard the presentation, the absolute importance of the discretionary welfare assistance scheme and the household support fund. So, any pleas we could make to the Chancellor or the government to continue the household support fund on a sort of strategic scale, and within our budget setting going into next year, I would be extremely reluctant to further reduction in need. Thank you. Next, we've got agenda item 8, Q2 performance report. Who's going to kick us off?
Chair, very conscious we've got a chunky item next, so I'm going to say very little on this, Chair, if you don't mind. Q2 performance report, usual format. We've provided narrative against each of the 4 key projects, and members will note they are all marked green, so on track, even though some have had revised dates. We have 2 performance indicators that are currently marked red. The first is around young people mental health support. That was the issue that was discussed earlier, the District Collaborative, and in particular Worcester City. As a council, we put some funding into additional support. It's a bit misleading because during Q1, that was the setup quarter. So there wasn't much that could have been done in terms of engaging with people. It was all about setting the project up. But in Q2, we have met the quarterly target of engaging with 40 young people. So we are really pleased with that. And we hope that will continue. And again, on-side advocacy have provided narrative there. And the other performance indicator that is in red is the exercise by prescription scheme. And again, that is something that we can pick up as part of the District Collaborative. Numbers have risen, but I think there are always some questions around this particular project, around why the numbers aren't higher than they are. So not having the detail tonight, and Alan, you not being around, again, that's something we can pick up as part of the District Collaborative. Chair, taking questions.
Any questions? Who wants to get on to the next? I mean, I think to flag up again, use of the household support fund and the numbers of households reached. So, over 3,000 households, if I've read this correctly, received support in Q2, which has made a huge difference to those households. I like to do my usual plug for Access Able, the Access Guide, which absolutely illustrates it's very much a live, ongoing project in the city. So thank you to officers and to everybody for the support and, you know, about making Worcester genuinely accessible. Thank you. Last but far from least, agenda item 9, bike share scheme award of contract. David's going to talk to us, and you're going to give the health warning about the...
Thank you, Chair, and thank you for that introduction to what I think is a very exciting project for the city. So this report is recommending award a contract to the preferred bidder for the bike share scheme. The name of the bidder is confidential pre-award. So I hope the report and the confidential appendices have given members a lot of information, sufficient information for members to make a decision on the award of contract. If there are questions or discussion that will identify the bidder, then we can move to closed session to do that. The recommendation is that the committee approves the award of contract to contractor A, as described in the appendices, and delegates authority to officers in relation with Chair and Vice Chair to finalise the details of that contract. The bike share scheme, the origin of that is in the Worcester Town Investment Plan, approved by the Policy and Resources Committee back in 2021, January of 2021. The business case for that was approved by Policy and Resources over a year later in the spring of 2022. There's an allocation of Towns Fund grant of £700,000 in allocation from the Towns Fund, which covers the cost of the scheme and also the council's mobilisation and contract management. The overall scheme will provide short-term, by-the-minute bike hire from bikes that we can collect and return to a number of specified locations right across the city, really giving access to facilitate journeys between residential, leisure, employment and educational opportunities. Some background on the due diligence that officers undertook in developing the tender documents. We commissioned a feasibility study that looked into a number of schemes across the city, across the country, with some desktop study and some interviews with 5 of those local authorities that were involved in those schemes, including 2 that actually were operated by the preferred bidder, which we weren't aware of. It indicated that a scheme would be feasible for Worcester with the funding available, something between 150 and 300 bikes. Fits with what was by the bidder. We also made reference to the guidance provided by Como UK, is the national charity for shared transport. Some of the research indicates, as I think it's an important point, that bike share schemes aren't financially sustainable without subsidy, either in the form of capital support on setup and mobilisation, or ongoing revenue support, the ongoing costs of running, or a combination of the two. I'd like to note that the Towns Fund provides primarily, almost exclusively, capital funding. So the contract proposed is that the council's funding through the Towns Fund will support the scheme setup and mobilisation costs, no ongoing revenue support or commitment. There were 4 bidders that expressed an interest prior to the invitation to tender stage. When it came to actually submission, 1 bidder submitted a proposal. Bidder met the fixed price of £600,000, part of what is a comprehensive proposal that meets our requirements for a sustainable scheme. Bidder also made a presentation to the council's major programmes reference group. The presentation is in the confidential appendix. Were present at that presentation. It's recommended that we award the contract to deliver the scheme to contractor A. There is in the confidential appendix a procurement report which explains the procurement process. So that contractor has met the requirements of the council. Proposed contract length is 4 years, with a provision to extend by a further 3 years. In the proposals that are put forward, there would be no additional cost to the council to extend after that. quick overview really of the infrastructure is what's proposed is 225 bikes. 175 of those would be e-bikes, 50 pedal bikes. Just to stress that within the contract, a minimum of 80% of the bikes will be available at any one time. So it is in the provider's interest to have as many of those bikes available. Cargo bikes aren't part of the current proposal. We have had some discussion how potentially they could be introduced. Sister scheme almost at a future date. That would be subject to a separate reports committee and a separate. The bikes are all monitored by a central network, so they're all GPS tracked, operated by app. Huge amount of data, position, speed, acceleration. There's a barometer in the bikes, so actually if a bike's lying on its side, the operator will know that and will be able to come and locate it. E-bikes have a battery range of between 60 and 70 kilometres. City of our size, that is a lot of trips around the city. Typically, the operator would come out and change the battery when it's in the report, page 32. There's an indicative map of the coverage. So, the intention is that 85% of the population of the city would be within a 5-minute walk of one of the parking locations. The bays are geo-fenced, so there is no infrastructure at the bays other than a line on the pavement. A small sign in some cases, but most of them will just be a line on the pavement, tracked through GPS. Photographs of those in your 3.17 talks about the hire and charges. I won't go through all the details there. We have benchmarked those. They're proposals from the provider that will deliver a viable and a sustainable scheme. They're in line with similar schemes now. 3.27, just some information about how parking behaviour would be managed and encouraged. So some penalty charges are proposed if bikes aren't left in the correct locations. It's about making them available for people and also ensuring that they don't cause an obstruction. 3.33 is that 5% of the forecasted rides will be provided free to targeted users. So it's work for us to do free, who those may be, lower income. Also 500 hours of e-bike rides to support social prescribing in the city. A bit earlier. Have some health. Just to note that upon award of contract, the provider will seek sponsorship for the scheme. There are some schemes nationally that have some major corporate sponsorship. That could be used to increase or target free and subsidised rides. Also, there are examples of employers who wish to subsidise or fully fund rides for their own employees. Maybe something that considers promote active travel amongst the council. There's some more detail at Appendix B on social value aspects of the bid. I'll just say here that the bidders scored very highly on social value. 9-page submission and 15 pages that are around social value. To emphasise the financial and budgetary implications, this is a scheme that's funded by grant from the Towns Fund for that purpose. Beyond year one of the contract, proposed that the contract management be undertaken by officers funded from base budgets within our ability team. The scheme is projected to be self-funding at the end of the 4-year contract period. So no additional funding is expected to be required. Council or provider may wish to bid for additional funding from other grant sources, enhance, extend or subsidise. Just moving to risks, there are some examples of schemes that haven't been successful nationally. The we've mitigated the risk of that really through a thorough procurement process to assess the suitability of the provider, and is a provider with a very strong track record of successful schemes. All of their schemes are still operating successfully. Of course, that reputation and financial risk of the scheme successfully is shared very much so by the operator as well. Engagement with accessibility groups is being undertaken during the mobilisation phase to ensure that the bikes don't cause an obstruction. And there are some examples of working with visually impaired groups. It is a concern clearly because there's infrastructure that will be in the public realm. That's something that's built in, and the provider has great experience around that. I'll conclude my presentation there, and of course I'm very happy to take questions.
Yeah, I think this is a really great scheme, and I would really like it to be like really desirable over using cars in the city. At the moment, with the cost likely to be £2 or £3.50, that's more expensive than some of the car parks would be. So has that been considered at all? I also have another question, because I can't really tell from the map because it's quite small. There's quite a large area in the city centre which you can't cycle through. It's prohibited at certain times of day. Has that been considered when thinking about where these sort of hubs are?
Thank you. To answer your first question, as I outlined at the start, this is a capital funded scheme. So we are reliant on our operator to propose what will be a sustainable and a viable scheme. So the prices there are what they use elsewhere and are comparable. We haven't specifically asked them to look at the cost of car parking separately to that. Second point, the intention here is that bikes will be available right across the city, very convenient, within a 5-minute walk or less. There are pedestrianised areas, there are areas that aren't suitable for cycling within the city. There are routes that move around those. So not part of the contract here to look at those.
Yes, I've got just one or two questions. The launch, which is proposed in 2024, you're looking at bays and beta trial commences. Is that across a certain selected part of the city to see how the bikes actually perform in that before being extended fully in there? That's the first question, because obviously I believe some part of the city, this scheme will be more suitable. I think another part of the city might struggle a bit, simply because of closeness to the centre of the city, and also perhaps socioeconomic groups of the people who live in that area are less likely to hire the particular type of bikes. I think the positive thing is there is although the bike I said before is very, very expensive, for a one-off pay as you sort of cycle, at least the night, at least the full day payment is quite a good tariff to encourage tourists and that for their benefit. I would suggest in terms of providing bays, a good place for bays is obviously looking at car parks we've got, because taking one bay out of a use could probably park about six bikes, because obviously you know, finding these sites is going to be a challenge, and scale you got, you won't be able to find all the time scales first away, and also I am slightly concerned in terms that on the page cycle one, where it's quite an expensive minute rate, it might encourage people to jump red lights and that sort of thing to keep their rental fee down. And the other thing is, I noticed if you park just outside the bay, you get a £10 penalty what happened if, for example, a very popular bay is absolutely full of bikes and you can't get your bike into the bay? Are you expected to cycle to another bay, or if you leave it just outside the bay, can you somehow contact the control centre to say, look, the bay is absolutely full, I put it as close as I can to it, therefore can the £10 fee be waived?
Thank you. A number of points there. I'll do my best to cover all of them. Please let me know if I don't pick them all up. The intended launch, the full launch of the scheme would be at the end of, towards the middle or the end of May next spring. The alpha and beta, the beta trial that's talked about is a tech trial. So what they've asked for is that perhaps we'll have 3 bays and maybe use city and possibly county council employees. So it's to trial the technology in the city to make sure that the app's working, make sure that the GPS is working. Then there would be a full launch in May. We've been back this point, we've talked about this point before, and we've been back again to the provider. They are strongly recommending, extremely strongly recommending that actually it's a big bag launch. A lot of work to do in finding all and agreeing all of the bays. But their experience over more than a dozen of these schemes, the best way to do it is to launch it all in one go, so that actually availability of the bikes is there wherever you are, rather than on specific routes. They've done quite extensive research actually prior to submitting their bid. Tell us they've been looking at Worcester for quite some time as a good potential for a scheme. So I found that very heartening. Absolutely, bays in car parks, a good location where they may be close to residential or destination. The point around the minute rate and the charging by the minute, that is the standard way of charging. I understand the point that you make. Otherwise, you would be charging, I guess, by distance. Quite sure how that would work, but looking at all of the schemes across the country, they all charge by the minute. E-bikes are limited to the speed you go. The last question is, what if the bay is full? The point of the penalty charge is to manage inappropriate behaviour. Bikes are left neatly next to bays. There will be a charge around that. What the operator is looking to do is to keep an even spread of bikes around the city in the different bays to meet the demand. So actually, if there are 10 bikes in a bay and it's overflowing, that would mean that the operator would know that and want to move some of those bikes and move them to another location in the city. So, I hope, Councillor Hodgson, that's answered all of your questions. Apologies if I missed anything.
Yeah, I think it does. I mean, somebody who works in logistics, I attended a very interesting seminar about the bag scheme and how it actually operates. Obviously, these sorts of schemes, they're about 10 years old now, but they're obviously becoming more into more and more cities. I know the GPS technology can work up to a point, but it's obviously got to be absolutely precise in that, because having used vehicle telematics and that, there can be an error factor in these things, so it is very important. That is absolutely critical. I know I did some work when I was vehicles versus shop location. I think we found, because there was like 100 meters difference in terms of where we thought the lorry was versus where it actually was. So it is quite important you get this telematic thing working.
Chair, thanks very much. A couple of points, if I may, both basically going in the same direction. First of all, potential for sponsorship. Now, aspiration, hope, assumption. The reason I sort of kind of flag this up is that as Councillor Hodgson has alluded to, there may be some groups within the city for whom this is potentially at the top end of what they might be able to afford, despite the fact they might want to participate in it. If sponsorship can be brought on board, that might, as the report says, it's perfectly obvious, that can have an effect on cost to customer. So, hopefully that will become a reality, because I think it may be something that can have quite a significant effect on what we're trying to do. Second point is that's raised just above it, which is subsidised rides. Now, we've all had experience in the past about trying to make this, and certain things we've discussed them relatively recently, more accessible to people who are on benefits or existing in a precarious sort of a way financially. So this is quite a key piece of work as far as I can see. How quickly can that come to fruition?
Thank you, Councillor Chair. I think just to address the sponsorship, I think it would be fair to say that's an aspiration at the moment. Until we have the provider on board, and actually they are far equipped to go and seek sponsors than the council would be able to assist with some introductions locally. Until you actually have a scheme, it's quite difficult to go and seek. So this is not predicated on a sponsor, but it's something we'd like to. There are many different ways really to work the subsidy, and I know something that providers used elsewhere is actually to subsidise routes rather than necessarily individuals. Because it's app-based, there is provision actually for text access, so not everyone has a smartphone, but it's primarily app-based. It can be done on an individual basis, as many of our subsidised services would be, but equally it could be done on different routes. So there's a potential to discount different routes. I'm going to give one example from somewhere else in the country where wasn't necessarily around this, but this was about influencing behaviour and changing the cost for different routes. They found that actually from one particular area of the city, all of the workers were using it to go and work in a particular factory on the other side of the city because there were no buses first thing in the morning. So a good number of bikes were tracking across to the factory and then being left at the factory. When it came to which meant that they all stayed there. When it came to the end of the day, there was a bus to go back. So actually the bikes were being left there and the provider was having to go and collect them. The local operator they used was having to go and collect the bikes and take them back. So what they did is they incentivised a ride, and if it starts in a certain bay, then there was a discount on that ride. I think they made it free for those because it was actually better for them, for somebody else to return the bikes than them to have to do it at the end of the day. It would be possible for us to certain locations where we could. So that's one way of doing it, or doing it on an individual basis.
Thank you, Chair. Excuse me. You won't be surprised to know that I am extremely excited about this scheme. I have a couple of questions. I wondered if the data sets recorded, if the big data could be sent to county to show how people actually travel, as opposed to how county might think people travel. Thank you. And I wondered if there had been any thought about workplaces perhaps getting discounts. You did sort of mention it earlier. I know that the NHS do schemes like this in London. I'd also like to note that for the Commonwealth Games, thank you, that the bikes were free. So perhaps if there are big events happening in Worcester, there might be sponsorship for particular events and particular days. Thank you.
Thank you. Yeah, a good number of suggestions there. Absolutely, the data can be heat mapped. Only a snapshot of cycling in the city, but it's available to see that. It's something we've talked about. We actually have a meeting with the Royal Diary, so that's coming up in the next couple of weeks. So we'd like to progress that with them. And yes, it's available to can make rides free. I think through all of this, what we need to remember is this needs to be a sustainable scheme and a viable scheme. So there's a point at which the provider can give away rides for free, but equally there's a point at which if we want to do that, very clear that actually we have no other funding. But 5% of rides free is a good amount, heavily involved in influence.
Thank you, Chair. Apologies if this information is in the scheme, I haven't found it. Is there a minimum height or age for the scheme? Or would there be a possibility of introducing perhaps bikes for children at a later date? And I was also wondering, if you have an accident, an interrupted journey, you get flat tire or something, is that possible to get your bike emergently off charge, because, you know, and report it as a failure, so that you're not going to get fined for being away from a bay? They're quite heavy. I've used these bikes myself. You don't want to be trying to drag one with a flat tire to a bay just so you off key it. So I assume there's some sort of ability to mediate with these people rather than get a fine and register that you've had this unfortunate incident and not being able to complete your journey.
Yeah, a really good point. I mean, I think the ethos of this scheme will make it popular. So we talked earlier about penalties for being out of bay. This is not about policing it and being able to impose fines. That the penalties are not how this is sustainable and viable. Those are to influence behaviour. They have recently in other places, which would be in this scheme, there's a provision if you're going to the shops and you stop and park outside, I think it's 20 minutes, but I have to check where the clock stops running. So you can stop partly on your journey and not have to park in a bay. So the way it normally works is you would ride to another bay, you would off hire, go and do your shop or go to the library, whatever you're doing, then you come back and you take what will probably be another bike and you go on hire that. So there is provision to stop. I'm sure the tyres are extremely puncture-proof, but it's a good point. Height and weight, I think there's a diagram in the appendix, but I won't look for it now, which talks about the adjustability of the bike. We've had one in this room actually and seen them. I'm sure there are minimum and maximum, but I think they cater for a wide range of heights and weights. Yeah, there is an age limit of 18.
We've had a report from distant places that the audio is a bit patchy. I've got Steve next.
Thank you, Chair. Yeah, thrilled that this has come back to us, and really excited to hear this proposal. Would just like to re-emphasise the words that we've had from Bike Worcester, really. You know, still a lot of work to do in Worcester City, and obviously this is a huge step forward in promoting cycling in Worcester, but a lot of work for us to do with our county colleagues to improve the road infrastructure to make cycling friendly. I had a question about the tendering process. So 4 expressions of interest, and one of those went through to submitting a bid. Did you get any feedback from the other 3 as to why they didn't put a bid in? One other question.
Don't have any detail on why they chose not to go forward. So I could speculate, but I won't do that in committee.
I was sort of a couple of questions around the same sort of theme of the ongoing theme. Once it's we've put in this sort of capital amount and the influence that City Council would continue to have over how it's run, because obviously it's a private venture Firstly, would bikes have logo on them? The sponsorship, would we have any say in what provides sponsorship?
We are proposing a four-year contract with the potential to extend by 3 years. So within that period of the contract period, yes, we have a lot of influence over how it's run. We will be a partner in the provider actually needs the council support to make this run, because there are a lot of stakeholders in the city, a lot of different locations. Obviously, the reputation of the scheme is all really in attracting. Through the capital injection, we are facilitating an operator to operate in the city, not a city council. So we won't be putting council logo bikes, they are.
Do we have any say in what companies might sponsor the...
Yes, yes, we would.
Yes. Will there be opportunity for members to suggest locations for bicycle location? They're often most familiar with their local communities and that. Certainly willing to suggest. Place these bikes.
Yes, most definitely. Do something to facilitate. There's a lot of work to be done and a lot of detail in a relatively short space of time. But I would certainly expect to have an event to engage with members who know their patch better than I do.
Thank you. Again, this is an absolutely brilliant scheme, and congratulations on all the hard work that I'm sure you've done to get it this far. I was really pleased that you said that you've got a meeting with Worcester Royal, because it feels like there's a real opportunity there for some working with the hospital. And Nunnery, the local residents are forever complaining about the amount of traffic, because people will park in residential areas to access the hospital. And I know that people who work there regularly tell me the reasons that they don't bike are, one, time. So if they're under too much time pressure to get to the hospital for a shift at 8 o'clock or 8:30, having to do a drop-off and all the rest of it. So if they're coming from St John's or Claydon's or whatever, it's just not viable in terms of time. And then also the security of the bikes, because there's regular thefts from the hospital property, which is why they don't bring their own bikes in. So if there was some ability to do some collaborative working with the hospital to say almost have like a park and bike scheme, maybe from areas that have got car parking facilities, aren't used much during the day. I'm thinking of sort of churches or some of the sort of areas. Get people on their bikes.
Thank you. We're, as I said, we have a meeting. Wider active travel, which would improve their scheme. I think the points you raise are some wider active travel. The allied pieces of work with the Towns Fund is some cycle routes. Hill, cards and coming up from County Hall. So actually those would serve the hospital really well. Yeah, the point about bike parking.
I think we've just about exhausted all the questions. Thank you for answering those. Thank you for all the work in bringing us towards this recommendation, the ability recommendation. I think, with modern technology and the availability of technology, being able to manage, there's whole other ways of managing where bikes are that maybe the general public or not everyone who is as IT sophisticated is aware. So I think that looks really promising. Reassured that there will be non-smartphone access options available, so we don't want to exclude a smartphone for any reason. And I think, you know, a variety of options about payment, ways to pay that will, you know, hopefully meet a variety of needs and tastes, and the options for working proactively with is really important. I'll move towards the recommendation. So colleagues, we have a recommendation before us that the committee approves the award of contract to Contractor A as described in the confidential appendices A and B to this report, and that the committee delegates authority to agree the final details of the contract to the Deputy Director, Corporate Policy and Strategy, in consultation with the Chair and Vice Chair of this. So all those in favour of the recommendation?
Microphone, that's bad of me, isn't it? Yeah, that's a unanimous vote in favour, I believe, yes.
Thank you very much. And just to be absolutely clear with terms of the confidentiality, we have made a decision today to go forward with Contractor A. So that, you know, the conversations, that is still commercially confidential. So the conversation, David will be going back to the operator, and there will be, you know, a launch public announcement in due course. So be absolutely clear, the pink papers, it remains confidential until that. Thank you for everybody's participation. I don't think we have any business. Thank you for quite a late night and for some very positive contributions. Thank you.